The coronavirus pandemic, of course, has had a dramatic effect on healthcare in this country. Perhaps the most serious impact has been on primary care doctors and clinics.
Many of them are closing up for good.
In the latest Larry Green Center survey, 47% have now laid off or to cut costs, but all of them are under pressure because they are having trouble seeing patients. And for the smaller practitioners especially, they have trouble getting PPE.
Once the pandemic began, telemedicine usage jumped almost 13,000%.
We have an opportunity to think beyond telehealth, but to also think about remote patient monitoring, digital therapeutics, kind of the full range of the ways technology can support engagement and serve as an extender or an enabler of care.
This is what I do. Personalized, relationship-based, integrated, equitable, and compassionate care. That is our mission.
Good afternoon. I'm Ann Greiner, President and CEO of the Primary Care Collaborative. And for those of you who caught that video, I hope you enjoyed it. Obviously, this is a very fraught time for our health system and for primary care in general. And today, we're going to hear from Ann Kenski, who's the lead author of a report that the Primary Care Collaborative put out in December, and two panelists who are reacting to that report about the state of primary care. I want to welcome you all to this webinar and just tell you a little bit about the Primary Care Collaborative, go over some housekeeping so that you're all aware of how to interact with us during the webinar and can put your questions as they occur to you into the chat. We will have a chance for a conversation at the end of this webinar. We are a membership organization that has over 60 members, and they are very diverse. They come from every stakeholder group in our health system, but they share a common commitment to making primary care more robust and more responsive to patient needs and preferences. We work mostly in the policy and advocacy domain, but we also disseminate research and best practices and do a whole lot of education around the value of primary care. We're really dedicated to advancing a health system that has a very strong foundation of primary care, because we recognize that that foundation leads to better population health, lower costs, and more equity in our health system. In terms of today, we have hundreds of people on the webinar, so we're going to really need to take your questions through chat. Many people sent their questions in advance, and we appreciate that. Your lines will be muted, so just so you know that. We are recording this webinar, and it will be up on our website within 48 hours, as will the slides, so you can share this webinar with your colleagues. So first, as I mentioned, Ann Kenski will lay out the data and the evidence related to this report. It looks at primary care spending very recently, between 2017 and 2019. The data is based on claims from Fair Health. All of the data relates to commercial health plans. So just to be clear about that, we look at national data and also data from all 50 states. The report also considers other peer-reviewed literature that's come out in the last year since we published our last report in this whole area around primary care investment. Let me now introduce you to our panelists and to Ann, and then Ann will take it away. So Ann Kenski is an advisor to the PCC. She has over 25 years of experience working in health policy and advocacy roles. She recently served as executive director of the Delaware Healthcare Commission. And from 2010 through 2017, she was Director of Policy for the Permanente Federation of Kaiser Permanente. Prior to that, she was Director of Healthcare Policy for SEIU. Connie Huang is a physician leader, and she has expertise in quality measurement and population health. She's currently at the Alliance of Community Health Plans, where she's Chief Medical Officer and Director of Clinical Innovation. And prior to ACHP, she was Vice President of Quality at Envolent Health. Prior to that, Connie and I crossed paths at the National Quality Forum, and she helped launch the Measures Application Partnership, a public-private collaboration that evaluates performance measures for CMS's performance-based payment programs. And just recently, Connie was appointed by the GAO to serve on the PCORI Board of Governors, which advises PCORI on its ongoing comparative effectiveness research efforts. So congratulations, Connie. Maureen Hensley-Quinn is Senior Program Director at the National Academy for State Health Policy, where she leads the Emerging Policy Issues team that focuses on state efforts to finance, provide, and improve coverage and care through public and publicly subsidized health programs. Prior to NASHP, Maureen was a medical specialist at the Community Transportation Association of America. And before that, she was a mediator and legal analyst within the insurance division of the Massachusetts State Attorney General's office. So we've got a fabulous panel, and to present the report, and Maureen and Connie to react. Maureen really from the vantage point of state leaders who are themselves trying to improve care for their constituents and purchase care that is of higher value. Connie from the health plan perspective, and health plans obviously are very much in the mix here as they try to figure out how to deliver more value for the healthcare dollar. Anne, let me turn it over to you.
Thank you, Anne, and good afternoon, everybody. I'm pleased to be able to present the 2020 Primary Care Collaborative's evidence report called Primary Care Spending, High Stakes, Low Investment. And there's a reason we call it investment. We, at the Primary Care Collaborative, we're very aware of a very strong evidence base that links the orientation of the healthcare system towards primary care and better population health outcomes for that healthcare system. And it's an association that was established by Dr. Barbara Starfield over many studies, over many years, looking across countries' healthcare systems. And we believe that primary care spending as a share of total spending is a good proxy for this notion of primary care orientation. We also think that primary care utilization and the primary care workforce are also good proxies, but for this evidence report, we really wanted to put out the most recent data on primary care spending that was available. And as Anne mentioned, that led us to Fair Health, and Fair Health is an organization with the largest sort of repository of private commercial claims for the United States. And they have so many claims that we were able to actually generate robust estimates for all 50 states. This particular pie graph that you see is from our 2019 evidence report, which was done in partnership with the Graham Center. And as you can see, the US we start from a very low base of primary care spending in the US relative to other countries. And as we discuss this, we'll also see great variation even within that low base across the 50 United States. Having trouble advancing my slide. Let's see here. There we go. Oh, wait a second. So the evidence report is divided into 4 parts. Our sort of original research is the estimates of national and 50 state estimates of primary care spending as a share of total spending. And then we're able to trend that data over the 2017 through 2019 period. In addition, we look at recent peer-reviewed literature on primary care utilization, as well as a recent peer-reviewed literature around the growth or lack thereof in the primary care workforce. We look at factors that may be driving our findings, and we look specifically at changes in health plan design in commercial health plans, particularly rising deductibles and cost sharing. And then the fourth part of the report really looks at what's happening at the state level. And there's a lot of really great state leadership and state innovation happening that we want to recognize. We created two definitions of primary care spending, a broad and a narrow definition of primary care spending. And there was we followed some literature that's been established in an attempt to kind of standardize these two definitions, with the biggest difference between the narrow and the broad definition kind of driven by the clinicians included in the services. What did we find? Well, strikingly, we find that actually primary care spending as a share of total spending declined between 2017 and 2019 for the commercially insured in the United States, and it declined whether we use a narrow or a broad definition of primary care spending. I'd like to say this is an outlier finding, but unfortunately, when we look at other recent literature using slightly different databases for primary care, some just commercial, some including both Medicare, Medicaid, and commercial spending, those studies also found a decline in primary care spending over recent time periods. So this seems to be a pretty robust finding. And there's also great variation across the states, and we'd like to learn from that variation. This is a map of using the broad definition of primary care spending, and there is about a 3x difference between the highest spending states and the lowest spending states in terms of primary care as a share of total healthcare spending. Oops, let me go back. We also found an association that was established, a similar association established in the 2019 Primary Care Collaborative Evidence Report, that states that have higher primary care spending tend to also have lower sort of ambulatory sensitive outcomes measures, and in this case, preventable hospital admissions. So then we take some time to spend looking at what might be behind our findings, and particularly, you know, in terms of measurement, the full report has a very detailed explanation of our methods and our data sources, but we want to just acknowledge that we know we are just measuring primary care spending using claims, the claims-based primary care spending. We know that there are other kinds of spending on primary care, non-claim spending, and we have a sense that that share is kind of been growing over time, but it's very hard to kind of get your arms around how big is it, how fast is it growing. We spend a little time looking at the state level to try to sort of inform this, but we know we are missing some spending. We also look at the some recent evidence that suggests that these rising deductibles and cost sharing levels in commercial coverage are in fact kind of discouraging sort of the high value care and the low value care. Consumers aren't really able to distinguish between the two. And then we also look at the possibility that we're actually increasing our spending on primary care, but we're increasing our spending on the rest of healthcare goods and services even more, things like drugs and hospitals, and we do see some evidence of that as well in the literature. So I just want to talk a little bit about this non-claim spending issue. And there's a couple states that have been real leaders in both measuring primary care spending, using policy to actually invest more in primary care spending in their state. And Rhode Island, Vermont, and Oregon are three states that sort of come to mind. And they're all also trying to measure primary care spending at the state level and the share of primary care spending that is non-claims included in that. And it's a very difficult kind of, difficult data challenge and data survey challenge. But what we find when we look at Rhode Island, Vermont, and Oregon is that all of those states do have a kind of a growing share of their primary care spending occurring in non-claim spending, but that it's still a relatively small share of the small share that primary care sort of accounts for in total healthcare spending. And in the case of Oregon, really their non-claim spending is skewed by one particular health plan, where it's almost all non-claim spending in that system. In the case of Rhode Island, they very consciously said, we want to invest in primary care, and we want to make that investment through payment and delivery reforms that are sort of done through a non-claims payment process. And this graph just indicates the very sharp rise in deductibles in commercial health plans, and that rise has outpaced the growth of wages. It's outpaced general inflation, and is really likely having a discouraging effect on certain care-seeking patterns. So to sum up, the report looks at primary care spending as a sort of proxy for primary care orientation. We also review evidence around primary care utilization, and most of what we see shows that primary care utilization is either flat or negative over the last 10 years, different time periods within those last 10 years. And then we look at trends in the primary care workforce. There, the picture's a little bit more mixed to positive, where the most recent data shows that the primary care workforce as a share of population is growing slightly over the last 5 to 10 years. Much of that growth is actually in the nurse practitioner workforce. And however, what we also see is that the rural-urban gap in terms of primary care clinicians per 1,000 population, or however you want to standardize it, we still see this very large and a gap between rural and urban in primary care workforce. And then finally, want to again recognize a lot of really positive activity going on in the states. Much of it predated the pandemic, and really just call out some states that have been measuring primary care and attempting to use policy levers like payment and delivery system reforms to really target primary care for increases in investment. And at the same time, many of these states who are targeting primary care for increasing investments using new care models and payment models, they also are trying to get their arms around the total cost of care and try to manage the growth in the total cost of care at the same time. And specifically during 2020, two governors, the governor of Pennsylvania and the governor of Connecticut, both issued executive orders to establish these total cost of care commissions and measurement processes modeled on Massachusetts, which was the first state to do this about 10 years ago. And at the same time that they're saying we want to manage our total cost of care growth, we want to target primary care spending for growth increases and really reorient our total system more towards primary care. So with that, Anne, I would like to turn it back over to you and look forward to a great discussion.
Thank you so much, Anne. And just to underscore, prior to COVID-19, the primary care platform was, frankly, diminishing. And this stretches back an entire decade. So even with the ACA and the coverage expansions and a number of policies within the ACA, we still have not seen this investment in primary care increase. And then we had the pandemic. Though I think we should take heart that a number of states continued to work on this issue of trying to invest more in primary care. Many of them spurred along by the experience of COVID-19. And I think and we hope that we're going to see even more states stepping up in 2021 to try to address these set of issues. We also know that states are going to be faced with higher Medicaid rolls because, those that many people have lost their employer-sponsored coverage, and that's going to also put pressure on the states to try to think differently about their expenditures. How can they use those dollars really to get the most value out of their healthcare spend to not only help the population health improve and address inequities that have gotten even worse with the pandemic, but also try to ameliorate some of the cost increases. So clearly lots of challenges ahead of us. We're excited that states and some health plans are stepping up to address these set of issues. And with that as a segue, let me turn it over to Connie for her reaction.
Great. Well, Anne, thank you very much. It's a pleasure to be on this panel today, and congrats on an analysis that's really eye-opening, frankly, about primary care spend and the trend there. So before I share some of my thoughts, let me give a little background about the Alliance of Community Health Plans. So ACHP is an association of nonprofit, regionally based community health plans that provide coverage and care for over 22 million Americans across 35 states and the District of Columbia. And our members are either integrated care delivery systems or health plans that are deeply tied to their community with long-standing connections to the local provider network. Some examples, just to give you a little snapshot about members at ACHP. These are health plans that include Kaiser Permanente, Intermountain Healthcare Select Health, Health Partners in Minnesota, UPMC, and Geisinger Health Plan. So I'm proud to say that of our 25 health plan members, they are often recognized as being leaders in population health management and have consistently very strong quality scores in terms of quality measures. And I think foundational to that has been an investment and prioritization in value-based primary care partnerships. So with that background, and when I turn to think a little bit about your annual report, I think you can't help but be a little disheartened by the low amount that you see in terms of primary care spending and frankly that downward trend. And then it immediately makes you think that if primary care spend, as you said, is on average something like 7.7%, it makes you question what else the healthcare dollar is going to. And I think we do have those significant challenges that Anne sort of outlined in that bar graph or in that pie chart. That we've got challenges ahead in terms of rising and high cost of drugs, emergency room visits and hospitalizations for events that could be avoidable with better preventive care and better chronic disease management, as well as low value care, which is not evidence-based and at best just wasteful, but at worst patients can get harmed by that. And these studies actually indicate that that's about 25% of our healthcare expenditures. I also think that when you think about this distribution of payment, that really is reflective of our fee-for-service, arrangement out there, where we are valuing volume more than outcomes at the end of the day. So I think at ACHP, we have some really good examples of members who are trying to counter that trend and in supporting primary care practice through value-based care payment arrangements. So while this can take on a variety of forms across our members across the country, I think there are really two main characteristics that you see in terms of these primary care value-based payment contracts. Number one, they are designed to pay primary care providers more than providers would normally receive under a fee-for-service arrangement. And number two, it really fosters alignment between the payer and the provider to focus on quality and management of total cost of care. And through that, it is really helping to transform primary care practices into advanced primary care practices that are patient-centered, can leverage technology, and really rely on team-based care. So I think when you reflect back on the past year with the pandemic, and I know it's been mentioned in some of your past webinars and at PCC here, but I think one of the key takeaways is that primary care practices that have made this transition successfully into a value-based arrangement where you are on, let's say, monthly global payments, you are more insulated, right, to those downturns in terms of face-to-face office visits and really those negative financial impacts. So I would say across our members and the clinical leaders working with their physician groups, from day one of the pandemic, when lockdown really hit, those practices could pivot very quickly to virtual care, to creative ways to reaching out to their patient panels, because simply there wasn't this nagging concern about, boy, how do I bill for that? Is that a billable service? How do I code for that? You could really spend more of your energies on things that actually matter. So the last thing I'm going to mention is that at ACHP at the end of September, we released a report called Healthcare 2030, Roadmap to Reform. And I think in there, I want to highlight two main aims that I think are really relevant for our conversation today. The first is that our ACHP members are throwing their weight behind completing the journey from volume to value. And then that secondly, really wanting to promote that aligned payer-provider model to really enhance the care that's provided. And so with that, in a separate sort of primary care issue brief that we put out there are 4 recommendations that our members are supporting. And number one, I think, folks on this call hopefully will be excited to hear it, but number one is really supporting doubling primary care spend by the end of 2030. The second is making permanent telehealth flexibilities that we've all seen have been tremendously important through the pandemic for patients and providers alike. Our members are also interested in looking at targeted federal and state policies that would really encourage a certain proportion of premium being devoted to primary care value-based arrangements. And then lastly, anything that we can do to support primary care workforce careers, because our members certainly recognize that we've got a rapidly, an aging population that's growing, and that is creating access challenges for some more of the difficult geographic areas. So with that, Anne, I'm going to turn that back to you.
Thank you so much, Connie. And music to our ears, those 4 policy priorities within the primary care space. And just to underscore, I'm not aware of any other group of health plans that have come together and said, we really need to invest, and have made that a policy priority. So hats off to you for doing that. We applaud that effort, and we invite other health plans to be so declarative with respect to investment in primary care. And to be clear, we think this investment really should go into value-based models so that we can provide the kind of comprehensive primary care that is delivered by a team. And that's really what we seek. We have a whole consensus set of recommendations related to investment. So we can incorporate behavioral health and connect patients to the community with community health workers and the like. So again, we applaud those recommendations. Now we'd love to hear from Maureen and gain some perspective about how states could use this information, again, information at every state level that they can compare themselves to their counterparts and against the national average. Maureen, over to you.
Thank you so much. Thank you for having this conversation, and thank you for thinking about the state voice as part of it. A little bit about my organization. The National Academy for State Health Policy is a forum of state officials that touch health. We recognize that health cuts across multiple agencies, and many have responsibility for it. And so we are made up of Medicaid, public health, Division of Insurance, state-based marketplace, directors, governor's office, legislators, and more, all really striving to do the best they can to serve their residents. And so that shows up in a number of different ways. I will say a lot of what was said today certainly rings true for work that we've been doing at NASHP. The economic and budget issues are real. The public health effects that COVID has brought are real. But what we like to say is, in a time like this, that's when you really need to call for innovation. This is when states can be their most transformative. And investing in primary care is an excellent way to try to do that. Some states, as has already been mentioned, are striving to do so. States have been making an investment in payment reforms, which have been meaningful and I think incredibly helpful, as you've already heard, but in many instances, it's not enough. States have a significant but limited role in some respects in changing the health system systemically. They are regulators, they are payers, but they can also share a vision and set a vision for reform that includes an investment in primary care, in value-based payments, and in investing in the health of their population rather than simply paying for when people get sick. And so it really is sort of reorienting or transforming, sort of turning things around. I look at this through several different lenses. So the first, looking at trying to rein in costs, is something that more and more states are really trying to do. Looking at this through trying to achieve affordability for both coverage, but also care. And so that means, as has been discussed, the cost growth benchmark or target of total cost of care that is being spent in the state, that is across payers, that's across hospitals, providers of all kinds, to try to get an understanding, both to get meaningful data to understand where costs are headed. Are they being spent in the right way? I think, as we've heard here, we can argue that they are not. And then reorienting where those costs go, adding in whether it be regulation, whether it be targets, but encouraging spend in the appropriate place. Another area is benefit design, and specifically looking at deductibles, which we know can really impact whether somebody seeks care or not, and when they seek care. And state-based marketplace plans have been trying to at least address some of this. So standard plan design is something that a number of states are trying, which is being very transparent in what gets covered when. First dollar care, meaning you don't have to go through your entire deductible before you can see your primary care doctor, before you can get preventative services and well visits. And then the other issue that we look at this through is a lens of social determinants of health. So social supports are critical to health. That's been proven in a number of different studies. And there are tools that states can leverage, like transportation, in order to access care. But there are investments that have to be made. And states across the board are looking for partners in order to do that. Health plans being one, providers being one. And then we'll also have to take a look at workforce. There is some leverage points that states have to incentivize workforce changes, encourage through loan forgiveness and other things, primary care providers, encourage new graduates to move to areas that need the care the most through tax reforms. So there are a number of things that states are trying, and The hope is that while there's no one silver bullet, that there are a number of policies that can get put into place, thinking outside the box, but sharing a goal of really driving investment towards primary care and high value care where it can make the most difference. With that, I'm going to turn it back over to Anne and look forward to discussion.
Thanks so much, Maureen. And I think you heard from both Connie and Maureen that it's going to take a multifaceted approach to solve this set of problems, and that while investing more in primary care is a really important solution, it's one of many to try to reorient our health system so that we're better able to achieve the quadruple aim. So really look forward to this conversation. My first question actually is for Maureen. Can you say a little bit more about what some states are doing through their exchanges to address financial barriers to patients getting primary care services, and also how they seem to be looking at this whole primary care investment piece?
Sure. So I'll try to consolidate. It's not a quick answer, but I will say state-based insurance marketplaces have tried to do quite a bit around affordability, looking at ways where they can further subsidize, some states further subsidize insurance plans. But short of that, taking a look at how the plans are presented on their platforms. We know that people are driven to choose their health plan during an open enrollment period, looking at a few different criteria, and expense and cost is paramount. And so trying to not just encourage people to go for the lowest cost plan, but rather highlighting what the plan offers. And these standard plan designs try to make it easier for individuals buying on the exchange to understand what they're purchasing. There's a number of things that are standardized, out-of-pocket costs, things like that, but also really messaging that there are pre-deductible services that can be accessed through these particular plans. It may mean that these plans on a monthly basis through premiums cost a little bit more because there are services provided before you work through your deductible. But so there has to be messaging, and there has to be some guidance offered so that individuals understand what they're purchasing. But they're relatively new. California, Massachusetts, Washington, I believe now Colorado, are all offering these kinds of plans so that individuals can further understand what they're purchasing and realize that health care very soon thereafter they purchase their plan, and not have to wait or perhaps never be able to see a primary care doc for fear of deductibles.
Thanks so much. So even some of these plans are waiving copays and deductibles so that you can get right to primary care. Yes, they do cost a little bit more, but then you have that immediate access.
Yes.
So, and also Covered California is collecting information about the plans that they contract with to understand what they're spending on primary care. So, I mean, I really think that there's a lot of innovation going on there. A question came through on the chat, and maybe if Ann Kenski could first answer this, and then if others want to jump in, that'd be great. Okay, so I'm a state official, and now I'm seeing that my investment in primary care is lower than other states that I think I'm analogous to, other similarly situated states. What have other plans done to try to address this issue? What guidance can we give them, knowing, and what you've been able to learn from interviews with states as you were putting together this report and other research reports?
Thanks, Dan. Well, I think I would point to some of the levers that Maureen mentioned, that states really do have a lot of levers as both a purchaser for their public employees, as a purchaser for their Medicaid program, In my home state of Delaware, I think if you add up Medicaid and the state employee plan, you're at like 20% of the state population almost. Now that's a little bit unusual, but you have some purchasing power. And then as a regulator, you also have levers. And specifically, you license hospitals and you license clinics, and you also license health plans. And if you have a state-based exchange, you have a little bit more control. You might want to think about having a state-based exchange. So I think it's really about inventorying your kind of levers, and then also just sort of inventorying this baseline, much more than just the primary care spending, understanding, you know, the distribution of your delivery system, where your providers are relative to the needs, relative to the social determinants of health needs. So really doing kind of a real assessment, but just seeing primary care as a real cost-effective value investment that you can make.
Maureen, would you want to add anything to that, or Connie?
I'd be happy to jump in and just affirm everything that Ann just said. States do have multiple levers, excuse me. The other area where I'd point out that there are, Rhode Island really steps forward as a unique example in this. And I don't mean to suggest that it's an easy thing to do, but using your rate review, your insurance rate review as a regulator in order to take a closer look at what plans you're approving to sell in your state, and the approval you're granting for premium increases. Rhode Island actually does require a certain level of investment in preventative care, and to have their health plans show that they've met certain criteria before approving a significant rate increase over the inflation rate. And so NASHP has actually learned a little bit more about this recently, and we're sharing a blog out tomorrow about it. But so just to add, I think many people think of states as the public purchaser, which they are, but they are also a regulator of not the entire insurance market, but of the fully insured plans, and do have an opportunity to add some levers there as well.
Connie, would you like to weigh in?
You know, I think Ann and Maureen have covered that really well. I think the one thing I would simply echo kind of earlier on in terms of what states can do and thinking about the design of some of the health offerings, I think value-based insurance design is really a principle that I think states can put forward and really be progressive on. And I know that our member plans are oftentimes trying to figure out ways to make the right thing to do the easy thing to do. Right? So taking away co-pays when it's really for primary care preventive type visits. There is an example of one of our plans that for a selected list of chronic diseases, really waiving any kind of cost, you know, for those chronic medications, et cetera. So I think there are clever ways, and a lot of great research groups out there. I think Mark Fendrick's group, Vivid out from University of Michigan, has great ideas on this, but how to essentially, you know, make it very easy and devote more of your dollars to that kind of high value care. And you can do that through benefit design.
Thanks so much. And actually, mentioning chronic care management, another question that came through the chat is, do policymakers understand the sort of disconnect between our expenditures, you know, in terms of chronic care management, because people don't just have one chronic condition, they have multiple chronic conditions, and all those expenditures, and the folks who are best positioned to manage multiple chronic conditions, which is primary care. So we're, on the one hand, spending so much to take care of patients with these multiple conditions, and on the other hand, spending so little to support primary care. You know, how do the policymakers understand that disconnect? Do they see it as a disconnect? Do they draw, you know, do they understand the relationship between the two? Maureen, you want to start?
Sure. I'll start by saying I don't know that everyone does see the disconnect. I think we're still learning, and I'll point out the state innovation model efforts that came from the federal government, from the Affordable Care Act. I think a lot of lessons were learned from those experiments that states undertook to bundle payments for chronic illnesses, some successfully, some unsuccessfully, but really encouraging, when doing that, to draw a straight line to the primary care provider, not to leave them out of the loop. I think what will happen soon, I hope what will happen soon, is we'll emerge from those experiments to a more thoughtful way to do this. But I think you're right. I think it's going to take some education. I think any kind of data, which is very hard to get, to really tell this story, I think is important. But then that's where your partners come into play, and thinking about Connie and her health plans and providers who can very articulately share those is going to be really important.
And I wonder if I could jump in and sort of build on what Maureen just said in terms of going back to the original question of how do we help policymakers really understand, what it takes to manage chronic conditions and multiple chronic conditions, right? And I would say for the value-based kind of contracts and programs that have been successful at our member plans at ACHP, it is such a strong focus on that multidisciplinary team. And I'm sure I'm preaching to the choir here at PCC, right? But, it's really that patient-centered medical home, advanced primary care model that really is relying on multidisciplinary groups. I saw a question come up in chat a little bit earlier, but what's the role of clinical pharmacists? I can add on to that role of behavioral therapists, behavioral professionals, right? Health that way. And those are really, like I said, investing in that type of structure and paying for that kind of team-based approach, I think, has been critical. Like one of the examples I'll mention, or maybe even just two, actually, Group Health Cooperative in South Central Wisconsin, one of our members, they have a staff HMO model, basically an insurance plan that's also healthcare delivery system, a clinic, right, that has multiple specialties, but they recognize the critical role of behavioral health, right, in any type of chronic disease management overall. And so they have worked really hard for the past, I want to say 7 years, in bringing those specialists on site, making sure that those providers have, flexibility in their schedule, maybe like a half day that's flexible to take walk-in visits from the primary care visits when they're done. If there's, an opportunity to walk that person down the hall and actually have immediate, services related to behavioral health and mental health. So there's been a lot sort of built around that kind of model to much success, where their emergency room and hospitalizations for behavioral health conditions have gone down. Patient satisfaction has gone up tremendously. So I would just say for policymakers, this type of team approach is really what's necessary for us with our aging population also, but just the multiple chronic conditions, behavioral health, clinical pharmacists, again, where you can have collaborative agreements where they have a lot of autonomy to adjust medication regimens. That's been super helpful. Kaiser Permanente has used that to a tremendous degree, especially in opioids management. They've been a critical, professional group in helping with that effort. So thought I would just mention some of those important examples that I think could be helpful for those policymakers.
Thank you so much, Connie. And just on this team-based approach, I mean, some analysis done by the Harvard Center for Primary Care, modeling, what percentage of primary care practice revenue needs to be capitated before it is sustainable for practices to build out a team. Because, it's very hard to build out a team if you don't know what your revenue is going to be, in the next month even. And so what they found is it's like 2/3 of your revenue need to be prospective payment for you to build out a more comprehensive team, and also to get away from, this is prior to the pandemic, to get away from this notion of face-to-face visits and get off the fee-for-service treadmill, if you will. So, you know, in the efforts that we're seeing around the country, it is about investing more in primary care, but it's also investing in these value-based models that, you know, set the practice up to really redesign care and to build out that clinical team. And some of the legislation, I'm thinking, and in Delaware, actually says, you know, if we're going to invest more in primary care, it is to integrate behavioral health. It is to improve women's health. It is to, you know, for primary care to bring in a community health worker to help connect patients to community services. So, you know, I think these efforts are about investing more and paying differently, both at the same time. Because without that team, you know, you are relying on then, you know, an individual to provide a whole battery of services that they don't have the time or the expertise really to do. So I just really want to underscore that point. And
there's something to add.
Yeah, please follow.
Oh, sorry, I'm going to add, and I agree. There is this critical tipping point, and it's higher than I think you'd want it to be honest, right? Knowing that, I think according to the Healthcare Payment Learning and Action Network, when you think about alternative payment models in the country, it's around 35% right now, right? Maybe a little higher when you look at Medicare Advantage, that's like gone over sort of the 50% mark there, but you know, I think there was this saying kind of early on in the value, you know, I think it still applies in the sort of the transition from, you know, fee for service to value. It's like straddling two canoes, but people always make the joke that, well, it is straddling two canoes, but one of them's a yacht, actually. So it's like a little difficult sometimes to make that investment. But I think what's been important, and I know, you know, across our plans, like you've actually had Dr. John Bennett, who's the CEO of CDPHP, on at a previous webinar, but it is important that these value-based arrangements really provide robust funding for primary care practices to do that change. And so for the EPC, believe it or not, for them, and they've been around about 12 years now, but they pay on average 40% more than physicians would get in a fee-for-service arrangement, right? And with a 20% opportunity for bonus based on quality performance and cost metrics. So I think more that you can kind of push in that direction, but it's hard. You got to get to that tipping point to do the investment, just as you said, Ann, to do the investment to get that kind of infrastructure and team-based approach to be active.
Absolutely. And we also need to get from these wonderful examples, Connie, that you're putting on the table, and many of them your members, how does this get spread across the country? So it's much more prevalent. And I think, you know, states see themselves as a way that they can help in the spread of these kinds of models by compelling the health plans that they regulate, you know, to put their expenditures, to shift their expenditures in a direction that is more primary care oriented. We had a question previously about the patient-centered medical home and that infrastructure, and you know, how does this relate to these conversations? And I know that it does in the state of Oregon. I don't know, Ann, if you want to comment on that, or just you know, really about PCMH and how it fits into this whole conversation about investment in primary care.
Sure, Ann. I think you're more of an expert than I am, but I think that you definitely see, or I think you see in a state like Michigan in our data that has kind of a dominant plan who committed to the patient-centered medical home several years ago, and really, I think, was able to get a lot of participation from the primary care community in that model in Michigan. And I think, you know, and this is just looking at claims from Michigan, the data is very impressive. It looks like Michigan is doing very well there. I'm not so sure that, to Connie's point, that, they probably still need to move more of their payment to support telehealth and support remote monitoring, all of the things that are sort of non-face-to-face, the investments that need to be made, they probably need to move a little bit more towards the capitation or prospective model.
Thanks so much. So I think what I hear you saying, Anne, is it's both the design, the patient-centered medical home, but it's also moving the payment more into value-based models. And so we need both. We need the reform of the delivery system and the reform of the payment. I will just say that moderator's prerogative here for a moment, that in Oregon, the legislature, who's a doc, who introduced the legislation for the state of Oregon to begin reporting primary care spend, and then they eventually set a goal for increasing primary care. Their rationale when they came to the state legislature was, look what we were able to do in the with Medicaid in Oregon, with a very robust patient-centered medical home model. Look what we were able to do with the state employees with a very robust patient-centered medical home model. And, we invested, these dollars in primary care, and we improved population health outcomes, and we reduced costs. And, that was their rationale when they came to the state, to say, don't you want this for all of the constituents in Oregon, not just those who are in the Medicaid plan or our state employees. And the Oregon legislature responded very positively and passed the legislation unanimously. So everybody in the legislature voted for this law that started the reporting of primary care spend and eventually set goals for primary care investment. So they are very much connected. We've got to both reform delivery and reform payment, and we need to do them at the same time so that we can really move the needle. We are getting very close to the top of the hour, and invite my colleagues if they want to add a last point, and we will wrap up. This, again, as I mentioned earlier, this webinar will be on our website and made available in 48 hours. So any last comments? Connie?
I was just sort of glancing through, and I know there's probably too many questions to get to, but there was sort of this one theme here in terms of the primary care workforce. And we talked a little bit about team-based care, but I think one of the other aspects of trying to move to these value-based arrangements or doing care, envisioning and performing, providing care in a different way. I think part of this is also to increase, or deal with burnout, right, with the provider workforce. And really, we got concerns about the primary care, provider pipeline. And I think some of that is really addressing, the moral injury that sometimes happens. There's just not enough hours of the day to do the volume, like in that kind of fee-for-service world. And so what I would point out for some of the groups, but again, another one of our members, Geisinger, health system, and they have a health plan as well. They've done this fantastic program called Geisinger 65 Forward, which is really for their Medicare Advantage patients, where they've created, I think, 5 sites at this point, but hubs where you have on-site primary care, lab, radiology specialists, nutrition, arts and crafts, got a community kind of center feeling, and it is holistic care that way, but done in a team-based approach. And I'll tell you, the providers that work there, if you came from more of a fee-for-service program, where you have a panel of 2,000, 3,000 patients, the panels there are somewhere between 400 to 450 patients, right? More time for every individual. Again, team-based approach, lots of services on hand there. And I think, as someone who, like I said, from a primary care perspective, I think that's what most people go into medicine for, and be able to have that kind of connection, et cetera. So it's great to see that some models will, also address some of these issues. And I think certainly other examples of just trying to get through the administrative, paperwork burden, the pajama charting time that kind of happens. And again, when the payers and providers are more aligned, you can get through a lot of that red tape a lot faster.
Thanks so much. And really important to recognize that it is about how we get to the quadruple aim, because the last part of that aim is, that the clinicians are feeling really good about the work that and the kind of care they're able to provide. And when they're not, it not only affects them, it affects the patient care too. And so, this really is about how do we reform primary care so that it meets everybody's needs, because then, we're going to be in a much better situation. So thank you all for your remarks and your time today. It was terrific. It was great to have you on this panel. And we look forward to further conversations about important topics.
Great. Thank you. It was a pleasure.
Bye.